Hi, hello everyone. It is my pleasure tonight to really be part of this panel for cancer nursing, this roundtable that's going to focus on HER2 new overexpressing breast cancer. I am Maria Theodoulou. I am the program director of the breast medicine program up at New York Oncology Hematology in Albany, New York. Exclusively see patients with breast cancer, young, old, both genders, and have a lot of experience with this particular subtype. Spent a lot of time at Memorial Sloan Kettering Cancer Center, medical student, resident, fellowship, and then full attending. Andy, would you give us a little blurb about yourself?
So I also trained as a fellow at Memorial Sloan Kettering, where I've been a member of the breast medicine service for about 3 decades now. And so predating the need to do HER2 testing, we didn't have such thing as HER2 positive or negative breast cancer in 1992 and 1993, as you know, and it was really the end of that decade where trastuzumab became the first HER2 targeted therapy. And about 5 years later, when we began applying it in the early stage setting. So it has been quite a journey, and it's wonderful to have patients who are in very durable remissions with metastatic disease, with HER2 positive breast cancer, many who are stage 4 NED, and those patients who have a high risk of relapse in the early stage setting, who remain free of disease after treatment. So a great time to be in oncology.
There's no question that during those late 80s and those early 90s, we were taking care of patients that were not responding to what we had in our armory, which was non-HER2 new directed therapies. And I know, Melissa, you were an inpatient on the inpatient service, and you saw a lot of these patients that unfortunately were progressing through so many of our therapies, often relapsing with CNS disease early on, before we really understood the natural history of HER2 new overexpressing breast cancer. Melissa Carver, hi. So happy to
Hi.
have you on this panel. Please tell us a
Thank
little bit
you.
about yourself.
Yes, Melissa Carver. I'm a nurse practitioner. I work for Florida Cancer Specialists, and my clinic is based in Tampa, Florida, but our clinics are all over the state of Florida. We're private practice, medical oncology, so we see whatever walks in the door. And of course, with the prevalence of breast cancer, that ends up being a pretty large population of breast cancer patients. But my background is starting all the way back in the 80s as a floor nurse in oncology, where most of the patients, of course, when they got chemotherapy, were admitted to the hospital. And yes, we always saw this population of breast cancer patients that we didn't know to call them HER2 new positive because we didn't know about it, but they were unique and they didn't do well. And it really was, a group of patients that had a very poor prognosis, which overall changed significantly once it was identified. And then we had the targeted agents to go after it. We really saw the complete shift in these patients as far as their prognosis. It's nice in some ways to be the old lady in the practice, because I've seen a lot, and it really puts a nice sort of historical background on things, even when I'm talking to patients as well.
Christine McGinn, thank you for joining us. I know you deal with breast cancer, and this is not a new concept for you. Please tell us a little bit about yourself.
Thank you for having me. Yes, I work mostly with women with breast cancer and also with GYN patients. I've been in the field for about 7 years as an acute care nurse practitioner here in Lifespan Cancer Institute in Providence, Rhode Island. And my original background actually comes from trauma, but then found myself in this beautiful field.
And how do you move forward, Christine, when you're encountering a patient who's just been diagnosed? They've been told that they have HER2 new positive breast cancer. So immediately they're Googling, and depending on what they Google, what they identify, yes, trauma will ensue psychologically and emotionally. What do you say to patients?
That's a good question. I mean, I think the first thing that they do is Google, and you can tell them to not do that, but they're going to do it anyway. So I think one of the most important things, and something that I take a lot of pride on, is education with my patients. And, I spend a lot of time with them and kind of go over, the different subtypes of breast cancer. And if obviously they fall in the category of having HER2 positive disease, that even though it's, many times worse prognosis, these new novel therapies are just evolving, and there's so much out there. And so that they don't look at this as a death sentence, but living with a chronic disease is often something that I really try to help them understand. And, these new therapies have been just amazing. I mean, people respond beautifully to them, and there's not as many side effects with these medications as traditional chemotherapy. So I think, letting them know that I'm here as a support person, and, we'll be with them every step of the way to manage toxicities and, what comes with being on a daily, treatment. So yeah, I think that's.
And I think, Melissa, you're very well aware that it's not just the recommendations we make based on understanding the histology, but it's also what the patient's goals are, where they want to go, what they want their lives to look like, and what their considerations are. And how do you address that with patients?
Certainly. And obviously we make the big separation between early stage curable disease, metastatic chronic illness, but hopefully giving patients a significant amount of time. And so particularly in those patients who are metastatic, clarifying their goals. Our goals may not be their goals, as far as the side effects that they're willing to accept or consider, schedules, sort of their goals of longevity versus quality of life versus I want it all, and then getting down into the nitty-gritty of the specific treatments and talking to them about sort of considerations related to their social status, their roles, their work life, their family life, and really just sort of getting into that deeply with a patient to understand not just what our goals are, but where they're coming from, because every patient is unique.